Hi and welcome to another video in the dermatology series. Today I would like to go over the methods in which you can describe a rash, just going back to the basics so that you're equipped with the vocabulary to accurately convey information to other healthcare professionals around you when it comes to any skin problems that you might come across. As a brief overview, I'll give you some of the basic vocabulary you should be aware of, the best approach to take when describing a rash, and give you some of the vocabulary for any nail changes you might observe, before going over just a couple of the red flags to be aware of. So let's start with vocabulary. There's going to be quite a few pictures. I think the best way to learn it is through a lot of visual input. So all the photos you'll see are from the website dermnetnz.org. Let's start with the first word, macule. So macules are smooth lesions, typically with color change. They are usually less than 1.5 centimeters in diameter, and very importantly, they're a flat lesion, so you cannot feel them when you run your finger across them. In comparison, there are also papules, which are small palpable lesions. They're usually less than a centimeter in diameter or 1.5 centimeters in diameter, depending on who you ask. Next, you have plaques, which are flat but palpable lesions. They have a degree of elevation, which might be present, but it doesn't necessarily have to be present. Next, there's vesicles. So vesicles are essentially small fluid-filled blisters. Another type of a vesicle is a pustule, which is essentially a purulent vesicle. So rather than filled with some clear fluid, it's filled with pus. Next, you have bullae, which are large blisters on the skin, which are filled with clear liquid, as you can see demonstrated here. So they're essentially like a very, very big vesicle. Wheal is another way of describing a papule, which occurs secondary to the swelling of the dermis. Wheals can be quite widespread and cover a significant portion of the body. It is often associated with an allergic response. Abscesses are localized collections of pus in deeper tissues. So in comparison to something like a pustule, an abscess is deeper in the skin, whereas a pustule would be collecting in the outer layers of the skin. And lastly, there are nodules. Nodules are circumscribed, elevated, solid lesions. They are bigger than papules. Those are just 8 of the most important words I think every person working in healthcare should be equipped with when describing any sort of rash or lesion they might see in front of them. There are naturally a lot more other ones, and I'll leave some resources if you want to read further. How would you actually describe a lesion? There's different ways of approaching it. I particularly like going through the size, the shape, the shade or color, the distribution, and palpation. So how does the rash actually feel? So now I'll just go over each step individually. Starting with size, quite easy. Essentially, how big is the rash? You don't need to give exact measurements, but it can be useful, especially if you have measuring utensils available. And it can help estimate the severity of the situation. So here you have someone with disseminated secondary eczema. As you can see, it is covering most of their back. I'll tell you that this is the back because it obviously is very hard to tell from the picture. Whereas, comparing it to someone with a individual lesion of discoid eczema, you would be a lot less worried about this patient. So communicating the size can be very valuable when discussing any dermatological lesions or rashes. Shape, starting with the outline, is it jagged or is it continuous? Is it well defined or is it a bit hazy? And is it a singular lesion or is it multiple lesions? If there are multiple lesions, are they discrete? So are they all individual and you can count them together? Or are they confluent? Do they sort of merge with each other and make it difficult to determine whether it's one lesion or two separate ones or two lesions that have merged borders. So in terms of the shape, here you can see a discoid lesion, a linear lesion. Here's a malignant melanoma, which is asymmetrical. And here is an example of confluent lesions. So as you can see here, the different pustules merge together, make it difficult to establish whether some of them were that shape originally or whether they merged together at some point during the disease progression. Next, starting with the shade or color, you can have hyperpigmented lesions, essentially meaning that the lesion itself is deeper in color than the skin tone of the individual. You can have hypopigmented lesions, which are lesions that are paler than the surrounding skin, and that is due to a degree of pigmentation loss. Depigmentation can also occur, and that is when pigment is lost completely, leaving white skin behind. So here we have a photo of someone with vitiligo. You can have erythematous lesions, which essentially are red in color due to the increased blood supply to the area secondary to the inflammation. Or you can have purpura, which is caused by bleeding into the skin. So there's microscopic blood vessels which are bleeding into the skin layer, causing this purpura to form. And lastly, you can have jaundice or yellowing of the skin, and there is a multitude of reasons as to why that might occur. It could be a metabolic disorder, it could be liver disease, etc. Naturally, you can have other colors. Lesions can be almost all shades. You can have purple lesions, blue lesions, greenish yellow lesions if there's something like a bruise. Next, let's talk about distribution. So acral means distal parts of the body are affected, so like your hands and feet. Dermatomal means it follows the distribution of the nerve root. That is the very typical presentation of things like shingles, as you can see on this individual here. Extensor and flexor are sort of self-explanatory, so very typical with things such as eczema and psoriasis. Very important to keep in mind when describing. Generalized when it's too widespread to really give it any individual term. Commonerized is a very interesting presentation. It means the lesions have appeared at a site of previous trauma or injury. There is hyperproliferation of collagen and there is more scar tissue built in the area following the injury, resulting in the lesion forming thereafter. Truncal means mainly the trunk of your body is affected, so things like your chest and abdomen. And photosensitive refers to any presentation of rash or lesions which occur in the typically exposed areas of the skin, such as your décolletage, your neck and chest, or your forearms and your hands. Lastly, when you talk about palpation, essentially what does the rash feel like? So you should consider the texture. Is it smooth? Is it rough? The firmness, is it hard or soft? When you press down on it, does it change shape? Is it quite easy to press down, or is it quite tough to press on? Is it mobile? Does it move around? Does it stay in one place? And is it tender to touch? Does the patient experience significant pain when you touch the lesion? All of these are very important to keep in mind as they can help narrow down the possible diagnoses. So here I have an example of seborrheic keratosis, which is a smooth lesion, and pellagra, which is a rough lesion. Now I would like to just go over some of the nail changes you might see. So first, very important, is pitting, which, as the name suggests, results in tiny pits forming on the surface of the nails. It's associated with eczema, psoriasis, and alopecia, to name a few of the conditions. Next, there's bowlines, which are essentially transverse lines that are caused by acute systemic illness, which temporarily prevents the nail from growing at the normal rate. Next, you have onychographosis, which is basically a very thick, hard nail, often said that it's in the shape of a ram's horn. It is associated with aging, but also psoriasis and trauma. Fungal nail infections, again, as the name suggests, but typically you would see a degree of breakdown of the nail itself and thickening and yellowing of the nails. Splinter hemorrhages, whilst not a direct change of the nail itself, splinter hemorrhages are associated with conditions such as infective endocarditis. Koilonychia is the infection of the surrounding cuticles of the nail, often associated with nail biting. It can be acute or chronic and often caused by Staph aureus. Clubbing results in a distorted angle of the nail bed, and it is often associated with low oxygen in the blood. So you can see it in patients with chronic obstructive pulmonary disease, amongst others. And lastly, one of the most important ones to talk about is koilonychia, which is essentially a spoon-shaped nail. It is associated most commonly with iron deficiency anemia, diabetes, and connective tissue disease. Lastly, before I finish, I would like to talk about some of the red flags to be aware of. If a patient has systemic features such as fevers, feeling generally unwell, etc., they should be seen by a specialist. If they present to your general practice and they might have a bit of an inflammation on their skin but also have significant fevers, you should refer them further for additional tests and assessments. Rapid onset or progression can indicate things such as anaphylaxis. So when you have rapidly progressing urticaria, you should be thinking about other possible emergencies. Things such as disproportionate pain when compared to the clinical presentation should make you think of other possible sinister causes. Lastly, changes in the appearance of the lesion over time, so things such as moles are important to think of. It can indicate things such as malignant melanoma, and therefore it is important to take a thorough history from the patient and see how and if they have observed any changes to any of the lesions on their body, as they will know best. That was a brief overview of different ways to describe the lesion. I hope it is a useful tool you can take and build on. I did not cover everything there is to cover. It is a very broad topic. I just wanted to give everyone who watches this video the basic toolkit on how to approach this topic and hopefully make it a bit easier for you going forward. Thank you so much for listening. I hope you enjoyed this video. I hope you consider liking and subscribing for more content like this. Thank you so much for watching, and goodbye.